I'm Dr. Tara, and this is Hopeful Hints, a podcast where you'll receive quick, hopeful hints on all things women's health and infertility. Here, you will find education, inspiration, and most importantly, find peace and empowerment as you walk through the next steps in your healthcare journey. Hello, and welcome to Hopeful Hints. I'm Dr. Tara Herding, and we are on part 3 of our 4-part series exploring endometriosis and excision surgery through my own personal journey. I feel like I have to disclaimer this because I put a lot of the Q&A out there, like ask me all your questions after my surgery. So this has been building since June of 24, and I'm finally getting around to it. We have so many questions we're going to go over, but in due time. I've been in my own healing recovery journey, and so I've had to wait for the right time to sit down and record this. A lot has happened professionally and personally with me, all great things, amazing things. We're helping so many of you women with endometriosis, but here we go. I'm going to stop yapping and we're going to dive in. You're going to want to stay tuned for this entire episode because there's so many questions that came from you, the listeners. I want to also say, if you have a question after listening to this, you know I'm an open book. Find me on social media. Dr. Tara Harding is my handle. Email, message, whatever. Open book here to help you. Let's dive in. Question 1. Did I need a bowel prep before surgery? No, I did not. This truly depends on your surgeon and their process and procedure, but typically a bowel prep is only needed for certain types of surgeries. Or if he thinks that you might have endo of the bowel, I find this to be a provider to provider, patient to patient decision. I did not need that. Number 2, this patient or individual who reached out said she has no symptoms before surgery. Now, all the time post-surgery, there's symptoms. Is this normal? So this is tricky because everybody, BODY, is different. And it truly depends. I see this happen more in adenomyosis. I recovered rough, but I had stage 4 endometriosis with a 2 or 3 centimeter nodule removed and adenomyosis that was wicked. So I typically find that my patients with adenomyosis, including myself, have a harder time post-recovery. I can't answer this question fully because I don't know how post-surgical they are. What I will tell you, you have to give yourself 6 months, if not a year. This is not a little surgery. Just because it's laparoscopic, as I'm air quoting if you're watching on YouTube, just because it's laparoscopic doesn't make it little. And this is, a lot of us have had extensive disease for a long period of time. There's a lot going on. Again, I just see adenomyosis typically recover worse. So I would prepare yourself, have a conversation with your surgeon, what to expect. I also would question this individual who did the procedure, because I have seen individuals who have, I'm air quoting again, excision surgery from a non-trained excision specialist do worse and flailing because you're not excising it. Typically, the people are not actually having excision surgery tend to do worse post-operatively. So a lot kind of goes into that. Number 3, did I compare my AMH levels before and after surgery? I did, and they fluctuated some. AMH, for those who don't know, is anti-Müllerian hormone. I am going through a fertility journey as well, and this is something to consider. There's a new perspective, though, that I want to throw out there to answer this as well, that really takes the emphasis off of AMH for fertility and really says, hey, let's look at the bigger picture, not just this sole lab factor as a predictor of your fertility. We have to also look at your age, your health, your egg quality. What are you doing, good or bad, that impacts your egg quality? What is your lifestyle like? What is your partner's sperm like? It's not just this like AMH is the queen of fertility anymore. I really want to help shift this focus away from AMH being this really big indicator of your fertility and outcomes and reduce that anxiety for you. And know that lower AMH really, there is actual things you can do to improve it. There is. I've seen it with my own eyes. We implement it in my clinic. And so I want to really encourage that, working with a healthcare team that knows how to improve or evaluate and do things to improve your AMH if you don't have a great number. Again, mine did shift very little. I still am shocked at my numbers for my age and all of that too. I was really worried about that. It was one that I literally closed my eyes and was like, oh, do I look at this? What's it going to do to me? Because I come from technically a decade of a fertility journey. My first IVF baby's turning 7 and I'm still in it. So I've been in this fertility journey a long time, and AMH was a huge topic and thing we looked at when I started. So I still have a little bit of anxiety around that myself. Number 4, can adenomyosis occur without endometriosis? I'm 55 plus with adeno. What's the best treatment plan? Yes, you can have endometriosis alone. You can have them both together. So very common to have just adeno, very common just to have endo, common to have both of them. So at 55 plus, a treatment plan really involves, symptom management or a hysterectomy. Do you want a hysterectomy or not? I did an episode with Dr. Adam Duke, and it was really good. And I really want you all to go listen to that if you are considering a hysterectomy. I don't care what your age is, but if the word hysterectomy is on your brain as a possibility of happening, please listen to the episode called Stop. Listen to this before you have a hysterectomy. You can't reverse that. So many of our patients want to do anything and everything possible before having a hysterectomy, and I like that plan. Again, it truly depends on the severity of your symptoms and your personal beliefs and feelings around what it's going to feel like to have a hysterectomy. A lot of women have a lot of emotional connection to that decision, and that's okay. You should. It is what makes you. That uterus is very unique to you. So I would say it is very fair to do everything possible symptom management-wise. Look at your hormones, do pain management before jumping into a hysterectomy. And if you've done all that and you're working with an entire team who understands this disease and you're still not getting good symptom relief, hysterectomy. Number 5, can I share about recovery in general? So I'm going to say this isn't a whole episode. Number 4, it's going to be in itself. Recovery varies is what I want you to know. You need to control that pain. You need to rest. You need to take time off work. I did not take enough time off work. That's my big takeaway. I took less than 2 weeks. That was not okay. I ended up taking over 3 weeks off. Take more time off than you expect you will need. It's typically easier for many of you to go back to work sooner than it is for you to be in a situation where you're not recovering well and then ask for more time off during that situation. Number 6, what about those who feel and present like endo, but get an adenomyosis diagnosis without surgery? So first of all, I'm going to say you cannot get an adenomyosis or an endometriosis diagnosis technically without surgery, and especially with adeno. Again, trained excision specialist is the one who's going to say, hey, this uterus looks like an adenomyosis uterus. They have to get in there and look at it with a laparoscopic procedure. You can't even really say that this is true. Adenomyosis can mimic endometriosis symptoms. So until you have that clear procedure for excision to go in there and look, you can't really say. A lot of times consultation calls are made and there's predictions and assumptions made. So that's likely what happened here. And that's normal. Get a second opinion. Maybe that surgeon isn't right for you. Get another opinion. Number 7, is the only way to confirm endo by having excision, or are there other ways? Yes, surgery is the gold standard procedure. It always will be what I recommend, but I know we cannot just go sign that dotted line tomorrow and make that decision. In our office, we do a procedure for some called Receptiva. It's a uterine biopsy. We love the Receptiva crew. Some providers will say you can do an MRI to see deep infiltrating endo. This is so specialized. Nowhere where we live in the Midwest, where I'm currently recording from, does this, but there are a few facilities that are trained to do this. I would call it a little bit of conflicting space with that. I would still say there's no true imaging that can say you have it or not. So no, I'm going to go back to surgery on this one. It really is a conflicting topic in the endo space, and it's be interesting to see. There's a new blood test coming out, supposedly. I actually talked to the company at conference about this. It's not out there yet. So it'll be interesting to see where that goes. But right now, my office is utilizing Receptiva if we have a very hesitant patient or it's very hard for them to get to surgery, or they just want to have a little bit of insight before they go, because we can look at the markers that Receptiva offers. Number 8, besides surgery, is it possible to reverse or stop endo? No. Surgery removes it. Nothing else will stop it, remove it, get rid of it, reverse it. You can manage symptoms, absolutely yes, until or ever surgery with supplements, treatments, diet, lifestyle, all the things too. You can definitely do that, but you cannot technically get rid of it or remove it without surgery. Number 9, I have PCOS, not endo, but your content has made me curious. Could I have both? Yes, friends, absolutely. We see it all the time. PCOS and endo coexist very often. The question number 10 is similar. Can you have PCOS and endo? I feel only half my symptoms are addressed. Yes, they overlap. We literally see hundreds of women every month in our office. Our crew does, and we see that all the time. Number 11, why is endo so common? How do we talk about it more? I love this question. Well, I'm very loud about this. I'm very passionate about it because of my own medical gaslighting journey through this, but increased awareness, better diagnostic tools are going to help us. Just keeping this open conversation with our friends, our acquaintances, our neighbors, our family, whoever, and then being educated patients can really help reduce the stigma and promote advocacy. Again, there's advancements like I talked about a blood test coming out. We got the uterine biopsy. We need more funded research. And that's something that only happens at the, national level, advocacy level, where you can join organizations and groups who are advocating around, and it's underfunded. Women's health in general is underfunded. Let me go on a small tangent about that. Fun fact, historically, medical research has predominantly involved male subjects. And this leads a huge gap in the medical field with understanding about women's health. There's a huge misunderstanding about endometriosis. There is an extremely high number of medical professionals that do not understand this disease. There was even animal studies done, and up to 80% of those animal studies were male subjects. So less than 25 of participants in clinical trials are even women. We have to fix that. And that's a really high level, deep, lofty goal. But it's being loud about this. It's teaming up with organizations and individuals who are doing the work to be loud about this. There's this male-centric approach that has resulted even in treatments for women being done on men, or the test subjects to medical treatment for women. It's just mind-blowing. And many aspects of women's health really just remain under research, and it really affects the safety and the utilization of medications and treatments available for women. Testosterone is another great topic of this. Shout out to Kelly Casperson. She's a doctor who talks a lot about this and talks about the underfunding and lack of research in women's health too for hormone health. So it goes across the board for women's health in general, let alone endometriosis. We have to keep being loud. Number 12, why does endo affect infertility? It affects infertility because it causes inflammation, scarring, and in turn, all of that can cause structural damage to actual reproductive organs. In general, the inflammation that occurs with this disease, because each lesion creates inflammation, can impair the function of the ovaries, the tubes, the uterus. Therefore, we have it difficult for an egg to be released or fertilized or implanted. Whenever there's scarring and adhesions in the anatomy, it allows for potential blocking of the tubes, which in itself prevents the egg and sperm from even being able to meet and do that. Additionally, when there's endometriosis, it just creates a hostile environment in the pelvic cavity. And so it is not a safe, cozy bed for that embryo to implant in. And these factors combined really just make conception in general more challenging. We really got to work on inflammation from a whole head to toe body approach to that. Number 3, what can be done beside a hysterectomy for suspected adenomyosis? So I kind of talked about that earlier. Symptom management. We love low dose naltrexone, supplements, peptides, pain management, pelvic floor PT, acupuncture, dry needling. You can preserve your uterus and do something like an ablation as well if the periods are just insane and you're done having children. So that was just a quick list. Number 14, I have a family history of endo and adeno. Is family history relevant? Yes. Genetics increase your risk. We know there's some genetic tendencies for this disease. A lot of them, I would say almost everyone in our office that we have a genetic connection. Each one of you and your family is going to look different. So don't compare yourself to your mom, your sister, your aunt, your cousin, whomever. My mom and her endo looks very different than my sister, than me. And so we all look very different with our symptoms and severity. Number 15, how much does someone typically pay for surgery? So costs vary widely. It depends on your insurance, your deductible, the surgeon you go to, the location. If you have garbage insurance, it will be covered at all. I really talk about and teach our patients, even if they have an insurance plan that doesn't cover it, how to go into the marketplace or switch over to your spouse's insurance if you have providers that are covered. look up their NPI numbers and do research on insurance coverage. Number 16, was Dr. Duke able to remove all of your endo or was some left behind? There's a video of him explaining, if you look on my YouTube channel, is a video of that. And he explains the findings to my husband, but my right ovary is essentially like a twist cone with endo. So there's endo left there. And my right tube also has endo left behind on it and adenomyosis. So yes, I still have some left behind. It's not going to be my first and only surgery. There will be more surgeries in my future. Number 17, what is causing such a prolific outbreak of endo in young women? I'm going to go back to it's always been there. We're just diagnosing it more. We're talking about it more. So it's unclear, but I'm going to go back to genetics because there's a lot of research happening with that and the genetic connection, environmental factors, immune dysfunction, and other resources. Who knows? More to come on that. But the genetic predisposition of endo can be passed down during conception. They're looking at like gene variations from one or both parents. And what that does is influences the actual function of like that baby or that embryo, that individual's immune system pathways, inflammation response, hormone balance. During fetal development, that's when abnormalities can actually form and for various things. But they're looking at, can the migration of endo-like cells actually occur during that process too, which then lays the groundwork for this disease to come to fruition. There's also some theories that are suggesting things like environmental factors that actually influence our parents. So were our parents exposed to endocrine disruptors? Could that actually impact the genetic expression of endo and increase the likelihood of that child having endometriosis later in life? Wild stuff, but I think it's one of those things too. Why does everyone have infertility? Why does everyone have PCOS? Just like all things in the medical field, advancements are made. We don't wear the same shoes we wore 10 years ago. We probably don't live in the same house we did 10 years ago. Medical science has advanced too, and social media has allowed for us to talk about these things more, so it just is out there more as well, is my theory. Number 18, was this an exploratory surgery? Yes, excision surgery is exploratory. When done in the hands of an excision surgeon, it's diagnostic and therapeutic. So you don't have to know that you have it. You just go to the excision surgeon. It's used to diagnose and treat all in one swoop. Number 19, do you think most women have endo, even without symptoms? Yes, Tara believes deeply in silent endometriosis. Silent endometriosis actually refers to cases where like an individual has endometriosis but does not experience any noticeable symptoms. My friends in high school and college are way worse than me. I'm fine. I breeze through my periods. I have no issues with my periods. Remember, most period stuff is adenomyosis. They feel good day in. They just don't have a lot of the symptoms of endometriosis until infertility time hits. Until they've done things like IUIs and IVF, and we're failing that left and right. This is where I think a lot of the silent endometriosis cases reside in. I also think a lot of silent endometriosis resides in the female who, again, has no symptoms and then has babies and now has symptoms. I see it both ways too. Number 20, have I had excision surgery before? In 2007, I had a lap procedure that due to a cyst that was causing issues. It wouldn't go away. It was getting bigger. And I later dug in my shoebox from high school with all of my fun handwritten notes from my friends with gel pens from 7th grade that I had tucked away in the back of the closet when I was moving. And I found the images of that surgery. And on there were the words stage 2 endometriosis and ablation. No one ever said anything to me about it, which is insane. So I was at the same facility when I was going through infertility and was diagnosed with unexplained infertility. Don't you think endometriosis should have been put on my chart if it was written on an image in a shoebox? I don't know. That's a whole story for another day. I've had a lot of issues as I'd breathed through these 10 years of my journey, but no, I've not had excision surgery before. Number 21, I went to a non-excision surgeon. Did I make a mistake? Yes, sorry. I'm going to be so blunt with this. You have to be in the hands of an excision. I believe only excision surgeons who do endometriosis all day, every day with resident training in that should be seen. And if you're still having issues, especially going to say yes to this, please make a consultation appointment. If you're still having whatever issues you had or reason for going to that provider are still there, consider a consultation with an excision. Number 22, can extreme fatigue be a main symptom of endo? Yes. Fatigue is a common symptom due to that inflammation and hormone disruption. Number 23, is surgery a one-time thing or will I need it again?
So some may need repeat surgeries due to disease progression, symptom management, complication. It just depends. There is a less than 10% chance of reoccurrence when done in the hands of excision specialists. Having deep infiltrating endometriosis has been associated with reoccurrence. That one, a study showed as low as 3.9%. Incomplete excision results in a higher rate, which was around 35.3%. So incomplete excision is where all the lesions are not removed or you had ablation. Advanced disease stage can really impact if hormonal fluctuations like high estrogen levels or an imbalance can promote it. I've seen some patients who had excision surgery and then go and do IVF treatment with that high surging of hormones can sometimes have a flare up in a repeat surgery. Age and fertility status, who you saw for surgery, what's your immune system like, what are your lifestyle factors like? Are you still following a poor diet? Are you still high stress? Are you still putting your body in a really inflamed situation? So a lot of factors can go into that. Number 24, do endo and adeno cause the same infertility issues or is one worse? Both can cause infertility, but I have been told by my provider that adenomyosis is more of the miscarriage risk, and endometriosis tends to have that more direct impact of not being able to get pregnant. Again, they do overlap. I wouldn't say one is worse than the other. I would say that, again, adeno carries more of the miscarriage risk, and we really have to bring in different protocols if we know we have adeno or suspect adeno, and really consider excision if we have endo. Number 25, again, a question was asked earlier, do you see adenomyosis with PCOS? Yes. So I have seen endo, adeno, PCOS, all three together. I have seen endo, PCOS together. I've seen adeno, PCOS together. 26, how to keep symptoms for a 13-year-old at bay. Again, working with a specialist who understands endo really early on. Do not wait. Do not let 13. I've heard some providers say they're too young. This is too young. There's no way they can have it, or we know. But then why are you giving them birth control? If you're giving a 13-year-old birth control for symptoms that are endometriosis symptoms, you need to be telling them why you're putting them on it. I see that happen all the time. So honestly, at 13, my recommendations are typically the same. We're talking about excision surgery. We're making lifestyle improvements. We're looking at supplements. We are doing pelvic floor PT. You don't have to be internal for pelvic floor PT. We're working with trained teams here of individuals. We're looking at what symptoms they have. So really depend on what symptoms that this individual has to determine what the right plan is. But I really base plans typically on severity and what are the symptoms. Number 27, what are your next steps for trying to conceive after surgery? I have been trying naturally. I did one IUI and failed. So right now, my plan is this. I have been faithfully doing my supplements. I'm doing acupuncture weekly. I'm on low dose naltrexone. I have a mental health team in place that I utilize. I do a spiritual team I have in place that I utilize. I have an IVF consultation I might be doing. I can't decide between 3 clinics. So right now, I have some consultations coming up for IVF and I'm living. I just got back from an acupuncture session actually as we speak, as I'm recording this. And I had a great conversation. And it's like, I think right now what Tara needs is just to live and focus on controlling what I can control and taking the steps towards having a child that someone would do if they know they have endo and adenomyosis, which is for me and what's best for me and my family is IVF. That's not for everybody. So don't feel like IVF is the only answer. That's not true. That there's other things we can do. And my age is a factor as well. I turned 39 in a month at the time of recording this. I'm okay with IVF from a personal standpoint. It is not, I have my own beliefs in it. And I believe my 7-year-old is a child from God, just like anybody else's who conceive naturally. So again, you're allowed to have your own opinions and views on that. I respect them 100%. That is a cool thing about me and my practice is we meet you where you're at. We are trained in natural family planning. We are trained in supplements, Eastern and Western medicine. We support you and where you're at in this journey. And I think that's what matters. If you're trying to conceive going through endo, please just know that you are allowed to feel and move forward with whatever plan is best for you. During surgery, does the excision surgeon clean out check fallopian tubes? So yes and no. He noted that what tends to happen in surgery is the tube spasm, so it can be hard to do. And that's exactly what happened in my case. He was going to try. He offered to try, and that happened. So I had it done in my office later on. My office is the only one in the Midwest at this time offering a very cool procedure with minimal to no pain for an HSG to check those fallopian tubes. And so I went and had it done there. 29. My sister-in-law says that endo is caused by parasites. What do I say? It was complex. It is not caused by parasites. Now, can parasites make endo symptoms worse? Yes. I have a provider in my office. She is a parasite queen. She's taught me a lot on this. Again, it's not caused by parasites. Okay. Endo caused by parasites can make the symptoms worse. Number 30. What's the recommended wait time before trying to conceive after surgery? So typically this is 2 to 3 months. If you have fibroids, it's going to be longer, like 6 months. Only your surgeon can determine this after your procedure, after they know the extent of what's been found. Depends on the findings. Number 31. Can I share more about thoracic endo? Is it included in surgery? So yes, the thoracic endo can be spotted and treated by a true excision surgeon. It is a real thing. It gets missed all the time. And again, you have to be in the hands of a trained excision for that to be found and treated. Number 32, does endo and adeno create risks for dangerous pregnancies? So there has been some research that shows that endo can have increased risk of preterm labor, bleeding, complications, but endo and adeno can cause certain complications just due to the impact they have on the uterus and that surrounding tissue and your anatomy in your pelvic cavity. I went digging and research showed me that preterm deliveries can happen. So due to inflammation and structural changes, small for gestational age infants can sometimes happen due to restrictions of growth. Placenta abnormalities can happen. And I actually had a placental bleed at 32 weeks. Found no issues, no causes. I never got an answer to why. So I found my answer to why in my research. You can have hypertensive disorders related to high blood pressure, including preeclampsia. So if that's happened to you, you should really be considering endo-adeno possibly in your history. And then miscarriage, again, the altered uterine environment for the embryo. So yes, the answer is yes. Number 33, what would I do differently after surgery if I had to do it again? So I would not be so scared. I would actually get my pre-op lab work. I would get my ultrasound done. I would plan my trip earlier. I would tell myself not to be so afraid, but give myself a hug. I would have also did it a decade sooner. I wish my healthcare team would have been more educated and informed on this disease a decade sooner, but I know research wasn't there a decade ago, right? So I have a lot of conflicting voices in my head about where my healthcare team has been the last 10 years. And I would focus more on recovery. I would take a longer time off. I would take 3+ weeks. I would let myself rest more. So really, I would have done it sooner. I would have booked that surgery sooner. I would have, even knowing 2-3 years ago where I was at with this, I should have booked it then. I should have booked it much sooner. But I would tell myself, it's going to be okay. You're in the hands of a great team. The experience from start to finish with everyone involved at the facility where I went was amazing. And so I just would have did this sooner. I tell my teens who come in our office that are my patients, I'm so excited for you because you're going to get to feel better sooner in life than many. You're going to get to hopefully bypass fertility issues. Hopefully your journey is going to look much different than mine and so many other women. You're going to get a better quality of life than many have. And so really just not being so afraid of this and booking it sooner. Having a whole healthcare team surround you, having different options for symptom management. So definitely would do things a little bit different. I am an open book on this. I want to thank you for taking the time to listen to this today. Reach out. I'm here for you. You're not alone in this. I can help find your team, help you navigate this. Again, open book, ask any questions. Thank you so much for listening. Stay tuned for next week's episode where I'm going to talk more about recovery.